Welcome, I'm Pat Schou. I'm the Executive Director of the Illinois Critical Access Hospital Network. I want to talk today about the importance of quality improvement in hospital operations. It's very important that we have quality programs going on throughout our hospitals, as well as performance measurements for our staff and our medical providers. Quality improvement has been around for years, back 200 years, but it really evolved in the late 70s and 80s when the Institute of Medicine, College of Surgeons all looked at performance of hospitals and medical providers. We started out in hospitals with looking at audits, like what was the temperature of refrigerators and whether you had a warming blanket after surgery, to now we really look at health outcomes. You know, the timeliness of seeing a patient in the emergency department, to whether the right x-ray was ordered, to whether we're able to decrease an A1C in a diabetic patient, to really all sorts of measures. We also look at readmissions of patients, which we've learned over the course of the last 20 to 30 years that quality does not always equate to more cost. We have to look at performance. And it's very important as hospital board members that you realize your responsibility as a board member for your hospital and understanding the quality. You want to be known as a five-star hospital, or the best quality, or the highest patient satisfaction ratings that you can have for your particular area. And so that's very important. Government, Blue Cross, Blue Shield, Aetna, all of the commercial carriers all look at quality and how that provides value to their beneficiaries and value to really people in our residents and in our communities. So it's very, very important that hospital board members understand the role of quality. And I'm very pleased to have with me during this conversation is to have Roxanna, who is the Regional CEO for OSF Healthcare, located over in the western part of Illinois. And she brings with her background experience in laboratory science, as well as being a CEO of a hospital. So she knows the relationships with hospital board members and their responsibilities. And so I'm very pleased to have this dialogue and learn more about that. So Roxanna, you've been, like I said, involved with hospital management and overseeing hospitals and working with many, many hospital board members. And how would you look at the responsibility of a board member? A new board member coming on, what would they need to know, and why is quality important to them?
Well, Pat, first of all, thank you so much for having this discussion with me today. ICAHN is such a great organization, and we're just privileged to be a part of that organization. So I appreciate this opportunity.
I'm thrilled to have you here. You know, we're colleagues at work here.
Yes, we are. So thank you. It truly is a responsibility that the board should be involved with as you said, the Quality Assurance Performance Improvement Plan, which we call a QAPI, which really spells out what the quality and safety of an organization, what it looks like, the structure behind it, and to have also those key metrics of what's important to the board. The responsibility of a governing board truly is to be fiscally responsible, but also to really be responsible for that quality and safety of all of our organizations. I know, working with a number of boards, that the reason they're on that board is because they care so much about their community, and they want healthcare to be in those rural communities. Both you and I, Pat, have such an incredible dedication, compassion for rural healthcare, and that's why you've been involved with the Critical Access Network for so long, and just as I have been in rural healthcare for a very long time. So I know the board members also, for each of our organizations, want that same high quality care.
Absolutely.
Many of them don't come from a clinical background.
How do you get them to learn more about the reports, Roxanna? What's your secret sauce here?
Well, the secret sauce is, first of all, I think always, every month, and most of the time our boards meet monthly, and I think that's very important. And we don't want to just have the financials. Every single month, I think it's imperative to also review the quality and safety of an organization. I always say our boards are the eyes and ears of our community.
Absolutely.
And they hear so much what's happening in the community, and they want to hear good things. But they also get tapped on the shoulder of maybe when things aren't going as well. And I think that's always a measure of what they hear in the quality, safety, or as you mentioned, with the patient experience. And so it isn't just on the inpatient side, it's on our surgical side, it's in our ambulatory clinics, and in our emergency departments. So all so important to be involved with the quality and safety of their organization.
Now, with your hospital programs, do they have a committee? Do they prepare reports every month or every quarter? How does that work, and what should a board member expect?
Yes. So every hospital should have a quality department, and depending on the resources needed for that particular organization, you know, the CEO or the president of that hospital will designate an individual to ultimately be responsible. And that person really needs to have clinical background, but really we have the capability to look at metrics and numbers, and also have facilitation capabilities to work with the medical staff and all departments of the hospital. Right. I know you have a nursing background, I have a lab background. It takes all of those clinical departments. It also takes our EVS staff, who are also instrumental in caring for our patients with those clean rooms. So it takes that whole team that really makes a good quality improvement program and project. So monthly, after we have this review of our QAPI and really approved by the quality department and then by the hospital itself, it really also needs to go to the governing board, who ultimately gives stamp of approval, but it can't be once a year. They do that once a year for an approval, but monthly, that quality and safety is really part of those meetings. And I think it takes time for all of us. We try so hard in healthcare to not use the acronyms that we're so well known for within our organization, but with our boards to really get down to and have the explanation of what is a good clinical experience.
I think you have a variety of programs that are in quality. You have probably things that are just statistically reporting, like if they have an OB department, what's the C-section rate, and so forth like that. And then you have an overall hospital reporting, such as infection rates and readmission rates, and then probably special projects and how you improve workflow in the admissions office and things like that. Are those some of the things that you share with your governing board?
Yes, all of those are part of our plan. However, we also know we have to focus, right? Because there are so many metrics. You mentioned earlier CMS or 5-star, and that's the journey that I know our organization is definitely on. Some of our organizations are 2 and some are 5. So how do we all get to that 5-star CMS? Very, very important. But we have to prioritize between the different domains.
I agree.
Of readmissions, of infection rates, of our patient experience, of our mortality rates, our ED, how quickly we are seeing our patients, many of those examples that you gave at the introduction. After we review all of that, we determine, we want our boards to know what we're doing really well on, but we also have to be transparent, and we know it's a journey, and what is our focus each and every year. So that's what we do, and that's what we have the review, and we stay on those metrics to review with our boards.
So you stay a whole year, but you sometimes will do the metrics the following year, the same ones if there's still improvement needed, or some you retire, so to speak.
That is correct.
And move on to another area that needs focus.
Yes. We keep our scorecard of really so many of those metrics so we know where we're at, because we also know CMS or Leapfrog, all
they're
of those.
Always changing.
They're changing, but they're also, we see national and state benchmarks, so we know how we compare, and it is with that comparison then that we determine what we need to work on in the next year. As you said, sometimes we're working on things for more than 1 year. As an organization, a little larger organization, we work on things for the entire ministry, but then we also focus individually at our own institutions where we know, but we learn from each other too. And I think that's what's so important with ICAHN. You have the capability. I know for myself and our OSF presidents, they reach out to you, Pat, and to your organization because very helpful in being able to get those benchmarks and working through you and your organization. Good. So thank you.
Well, one of the challenges small rural hospitals, critical access hospitals have is that some of their quality numbers are insignificantly significant, so to speak. In other words, there's not enough admissions sometimes a month to measure for customer service, hospital consumer reports and things like that we have the HCAHPs. So how do you help an organization like that if they have less numbers to really use?
Correct. I think many times that's why they don't get the ratings, but we still look at every patient every time. So when we do every one of our critical access hospitals, we do ED caps, which is how our consumers assess us in our emergency department. We also do that for all of our hospital admissions. And so every patient will get that survey. Now, we always encourage our patients to return those surveys because that's also important. And we also have what's called CG caps, which is in our ambulatory space or our physician offices. That's probably where we get the most response because we see more patients in that. Our number of surveys being sent out are larger. But so when those areas, we do the comparison and we see every month, we address those comments monthly. And so we see that. And so we do get in the CAPS area enough survey information. I think it's many times on when we're talking about falls with injuries or infection rates.
Medication rates.
Medication rates. Yeah. Those are at a much smaller end, but we really know we want zero. Because if you look at any of the comparison in our critical access hospital, in order to be in that upper quartile or that 90th percentile, the answer is zero. Zero infections, zero falls, and so that's really what we strive for. And happy to say, many of our critical access hospitals are at those zeros, so very proud of the work that they have done.
Your group does very, very well, and they've been very helpful to others too in sharing information about programs that have been successful. From your experience, Roxanne, has there been any particular quality improvement you thought made a difference in one of our small hospitals or with the system itself?
Well, probably one of the areas is, but I'm going to talk about my lab background because I love that, and that's where having zero infections I think is so important. But one in particular is probably with Clostridium difficile, which is a normal flora in many of our bodies. However, does it cause an infection or not while you're in the hospital? It's called hospital-acquired Clostridium difficile. So one of the areas there is really the process to make sure we're not testing unless we're testing that the patient is symptomatic. And so I think that process, and that's what's so important with so many of our metrics, that we really have the right processes set in place in order to have the correct result. Also, when we look at our infections, or more so, let's talk about in the emergency department, the importance of individuals not leaving the emergency department because of it being too busy. So really looking at our resources and our flow, I think is another area of great importance. Again, as a governing board, one thing that I feel so strongly, you wouldn't be on that board unless you didn't believe in your organization, and more importantly, that healthcare was present in our rural communities. And so they want to assure, if they went to that emergency department with the symptoms of a stroke or having a sepsis occurring quickly, that our physicians and our providers will really respond quickly and appropriately.
Now you mentioned physicians and or practitioners. Our world has expanded with medical providers. How do you engage them with your hospitals into the quality improvement program? Do you have any tips that you can share with our hospital boards?
Yes, well, without a doubt, with the quality department, and when I talked about whoever is responsible for quality specifically within that organization, quality, safety, and risk. Again, reporting up to many times the CNO, and then ultimately the CEO, and then to the board. But our physicians or our advanced practice providers, because we really do have more advanced practice providers working within our rural clinics and in our hospitals than we do physicians. But the importance of medical staff also being involved with our quality committee is very important. And so I think another way to get them involved with our board is we like to see the president of our medical staff in that particular year also to attend the board meetings, and for the community and the boards to really get to know them also. I know time is important to all of us, so we also feel that the timing, so that we're not taking them many times out of their clinic or seeing patients, so really working with their schedule also. But many of our rural physicians and advanced practice providers also so committed to our communities and to assuring healthcare is local and that we can continue rural healthcare to the degree that we have in the past is so important. So we want that commitment from our physicians and providers.
Well, and I also know that many of the hospitals have moved to including quality measures in their performance improvement and their reviews and things like that, not only with physicians and practitioners, but also with staff. Have you started doing that within your organization?
Yes, we have. You know, I think when we talk about peer review, or again, the evaluation of all of our providers and both our physicians and our advanced practice providers, they all individually have their own scorecards. You know, so when we look at our HCAHN scores, which is our patients, what they say about their stay, either in the ED or in the hospital, we can also delineate that per provider. So they see those scores. You know, sometimes N's are small, the denominator is small, but they want to know what the patients think and say about them, and so we share that with them. Not in a punitive way, but in transparency. Nobody goes into healthcare, I believe, just as you and I, without the real commitment to improve clinical excellence within our communities and truly the love of rural healthcare.
And that's very, very important. And in closing our discussion, you know, we've covered a lot from practitioner involvement, from the importance of board members looking at the reports and asking questions and so forth, and how we evaluate the hospital with star ratings and all that, and how important that is to perception and maintaining the best for our rural communities. But what would you like to say to other hospital board members when, in closing, what would be one or two things that you would like them to take away from our discussion?
Well, Pat, thank you. First of all, for them to understand that it is a journey, that they have to know where we're starting at what point we're starting at, in that comparison. There's so many metrics out there, so many benchmarks out there, and we can't be perfect with all of them, but to know which ones we need to work on. I also would like to say that every patient really does matter, and how we treat that patient with that love and compassion. So those patient outcomes, that patient experience is so important. You know, today everybody wants things pretty quickly, and so how we respond and really be compassionate in that response to our patients.
Well, those are excellent remarks, and I thank you for your time today. I see the good work that you and OSF and others do for healthcare in our rural communities, and it makes a difference. And that's why we wanted to bring this quality discussion to other board members today, so that it stimulates their conversation and realize how important quality is in measuring what we can do and how we can be better. Because it's really still, as you said, the patient experience. It's always about the patient.
It is about the patient.
Thank you, Roxanne, for joining me today.
Thank you, Pat.